Hello, check. Hello, check. Check 1 2 3. Check. Hello.
We request everyone to kindly assemble back in the hall. I kindly request the delegates to get back to the hall. I kindly request the delegates to please assemble back in the hall. I request the volunteers to kindly guide the delegates back to the room. Volunteers, kindly guide the delegates back inside. I request all the delegates to kindly assemble back in the hall. Now that we've had a nice cup of refreshing tea and some snacks, moving on, we have our next session by Dr. Asha Kiran sir. I request Dr. Reena R, our Professor of Biochemistry, to introduce sir.
Thank you, Josna. Very good morning to all. I'm privileged to introduce today's esteemed speaker, Dr. Asha Kiran, Principal, Professor and HOD, Department of Biochemistry, Haveri Institute of Medical Sciences, Haveri. Sir is a distinguished biochemist and medical educator, over 23 years of experience, graduated from JNM College, Belgavi, and MD in Biochemistry from JSS Medical College, Mysuru. Sir has exhibited remarkable leadership and management skills as a professor and head of the Department of Biochemistry for more than 11 years and served as the Director of Diagnostic Laboratory Services for 3 years. Sir's academic contributions are impressive with 26 publications in reputable journals and authored 3 book chapters. He actively engages in scientific discourses, presenting papers and participating as a guest speaker and panelist at various conferences. We would like to recall Sir being the quiz master along with Bindu Madam when our department hosted state level Epignosis 3 quiz competition in the year 2018. In addition to his teaching role, he has been a pivotal member of Board of Studies for both undergraduate and postgraduate programs and is a respected mentor for MD, MSc and PhD candidates. His accolades include securing the first rank in MD Biochemistry, the Best HOD Award and the esteemed Brigadier Ramesh Sinha Award for Best Paper Presentation at Ambicon 99. Committed to continuous learning, he has completed numerous professional development courses including FIMER and advanced course in medical education, NABL internal auditor training, NABL assessor training, certificate course in evidence-based diabetes management and a postgraduate diploma in bioethics. Beyond his professional endeavors, he has a creative side too, interested in singing, t-shirt painting, sketching, and acted in 2 Kannada films and web series. A sports enthusiast, he enjoys cricket, badminton, table tennis, and carom, won many recognitions in various competitions. With this diverse expertise and passion for teaching, research, and personal growth, Sir is a valuable asset to the field of biochemistry and medical education. Now I request Asha Kiran Sir to unlock the cancer biomarkers, a step towards
Yeah, thank you very much. At the outset, I would like to thank Bindu Madam and her team, Biochemistry from Rajarajeshwari Medical College, to giving me an opportunity to be here with you all for this program on cancer. Particularly this February month, 4th is the World Cancer Day. I think many of them observe for a week about cancer awareness programs, and this is the right time to have thought about this and have this CME today. Second thing is, Madam has told, please be short, okay, so that we are a little bit running out of time. I'll try to finish the things quite whatever they have asked for, okay. Yeah, because even cancer biomarkers is a huge topic. Okay, to go on exploring things, some newer things which has come up. I'll try to touch upon all the things and try to put it across so that it's going to be useful for both clinicians as well as the other experts who are sitting here. So we'll unlock the things of today's talk in these 6 headings. First, we will see about the biomarkers. Then we will move on to the markers of cancer. Then there are various types. We can categorize them and we can look at the types of cancer biomarkers. We'll move on to the precision medicine and cancer care, because this is the new thing which is going to come up in next few years of time. Challenges and future directions, and then the future of cancer research, we will discuss under these things. So biomarkers, there are various definitions which are given. Okay, so National Cancer Institute has defined it as a biological molecule which is found in blood or other body fluids or tissues. That is a sign of a normal or abnormal process or of a condition or a disease. Mainly they consider this as one of the molecular marker or signature molecule. Dictionary is going to define this as a biochemical feature or facet that can be used to measure the progress of disease or the effects of treatment. Center for Biomarkers in Imaging, they have a little bit of different version of the definition, but the meaning is almost the same. They include anatomic, physiologic, and biochemical or molecular parameters which are associated with the presence and severity of specific disease status. And Biomarkers Consortium defines this as the molecules which has got characteristics that are objectively measured, and they are evaluated as indicators of normal biological processes, pathogenic processes, or even the pharmacological response to the therapeutic intervention. Okay, so whichever things are, I mean, the meaning is almost the same, but the entities in which things are included here and there is a little bit variation in this biomarker. Anyway, what is the role of biomarkers in cancer? I think we all know about this. It helps in early detection and diagnosis, the first thing. Second thing is monitoring of cancer progression. Third one is about the treatment response, how the cancer is responding to the treatment. And fourthly is it acts as a guide for personalized treatment plans. Okay, so that is what is the new focus is all about. I think that is where we are moving in that direction. So markers of cancer, cancer as such, I found this is one of the thing what we can tell about the cancer. It's an intricate condition marked by the genetic and epigenetic changes. I think Anita madam was highlighting about both the things, and that throw off the balance between the cellular development and cellular death. Okay, so I think that is where it ties in. So it's nothing but the uncontrolled progression, or cell is going to divide uncontinuously, is not necessary. And if you look at the markers of cancer, so biofluid biomarkers is what is our focus, but there are other things also which are included, which needs to be included, not be excluded. Imaging biomarkers are there, which are derived from medical images. There are biopsies which is going to help in the diagnosis. It can be surgical biopsies or endoscopic and needle biopsies. Then tissue imaging, the immunohistochemistry is also going to play a role in the diagnosis. But now we will focus, as a biochemist, I can focus more about the biofluid biomarkers. Okay, so that is what we will focus about. Classification of biomarkers, you have diagnostic markers, which I'll be telling the things. There are also some prognostic markers, which is going to provide us the overall cancer outcome, and regardless of therapy, by predicting the disease progression and the patient survival. Okay, so there are markers which are there, and there are predictive markers which is going to help us to explore or likely benefit from the treatment, identifying which patients are likely to respond to a particular therapeutic intervention. Okay, so that is what we are going in for, the precision medicine, where this predictive markers is going to help us a lot. Categories, mainly we can classify into these three broad categories. One is the genetic markers, the other one is protein markers. Genetic markers, basically we have the oncogenes, mutated forms of the genes that drive the cancer progression, and also tumor suppressor genes. I think Nita Bijur madam told about these two entities, okay, which is crucial for to keep a check, okay, on the cell progression, cell division, and cell death. Okay. That is what is going to cause balance those things. There are protein biomarkers. Mainly, there are two enzyme biomarkers which are there. You also have the receptor biomarkers. Okay, so which are proteins which will tell us about the abnormal binding activity things in various cancers. And we have the hormones which act as biomarkers. And of course, the metabolic biomarkers are the things which are there in the metabolic processes that signal the presence of cancer, altered metabolism. Or also, there are some lipid biomarkers which tells us about the changes in the lipid metabolism that can indicate the tumor activity as well. So we'll move on to the various types of cancer biomarkers. So I'll focus on these 9 types, and we will explore each one, what way they are going to be helpful for us, either for diagnostic or or for the predictive, how the changes is going to take place in them, and what they indicate to us, these types of. So you have genetic and epigenetic markers as first in the list. Then we will focus little bit about the protein biomarkers, then metabolic biomarkers, then the cells itself can act as biomarkers. So these are all the cells which will act as biomarkers. Then we have inside the cells the lamins which act as biomarker. Then galactins, because these two entities are the ones which are lot of research is going on. That's why I put them in the list. And carbohydrate antigens, we know about it. Certain viruses also can act as biomarkers. That is just to complete the list. And lastly, we will move on to the exosomes which act as biomarkers. So we'll focus on genetic and epigenetic markers. Mainly, we can divide them into 5 entities. First one is mutations and gene alterations. I think this we all know, the BRCA1 and 2 mutations, they increase the risk of in breast or ovarian cancer. Also this human epidermal growth factor, HER2 amplification or overexpression, it is going to indicate the aggressiveness behavior of breast or gastric cancer. Okay, so these are all the things which are related to mutations and gene alteration. Related to gene expression profiles, analysis of the patterns of gene expression can be done, so that it will help us to give an insight about what are the changes which is taken place in this cancer. For example, oncotype DX expression is the one which is a panel of 16 genes which are studied, and that is in breast cancer. And similarly, Decipher is another entity which is going to evaluate the gene expression in prostate cancer. I just taken a couple of examples to highlight about those things. DNA itself can be acting as a genetic marker. Okay, elevated concentration of serum DNA, which have been linked to the particularly to the metastasis. Okay, so whenever there is some metastasis which is suspected, that time we can use DNA. These are nothing but the oncogene alterations which can be studied, mismatch repair gene mutations, and mutations in the tumor suppressor genes. Particularly the tumor suppressor genes are the one which is taken into account and studied, and they can be used as DNA markers. Coming to RNA as a marker, so it's the expression of particular type of microRNA. Okay, so miRNA population, which is related to the clinical features in a time or tissue dependent pattern. So that is what is studied, and it will act as a marker, because these RNAs, they regulate the transcription of the target mRNAs, and that is the one which is involved in the mechanism of causation of cancer, because they promote tumorigenesis, metastasis, even immune evasion and angiogenesis. And last but not the least is the epigenetics, which comes into picture. So epigenetic markers are little different, because these epigenetic alterations, they are potent biomarkers. It happens for specific genes and they are stable. by it can be detected, and even by minimally invasive mode they can be detected. And as Nita madam was telling, the DNA methyl transferases, okay, so that is the one enzyme which is going to be involved in hypermethylation of a promoter which is going to silence the tumor suppressor genes. So that is the mechanism in which they act, and that's why we can pick up this one as a genetic marker, epigenetic marker as well. Next, moving on to the protein biomarkers. So we know that proteins, they modulate the molecular processes and pathways in the normal as well as cancerous cell. And cancer, I think they are the ones which are more relevant for the tumorigenesis and progression of the cancer. And certain protein biomarkers, we already know the protein biomarkers in particularly in pancreatic cancer. They are found in bile, pancreatic juice, urine, and also in the pancreatic cyst. And we are already utilizing some of these markers both for screening as well as diagnosis, even for the classification or staging of the testicular cancer, like HCG, AFP, and LDH levels are utilized. Similarly, the expression of HER2 or NEU and cytokeratins, they can be applied to improve the breast cancer prognosis. So these are the protein biomarkers which some of the things we are familiar and we are using. Some of the things are little advanced and we can do it so that we can not only just diagnose, but it's going to help us in the knowing about the progression of the disease as well. Metabolic biomarkers, okay, in MBBS we all ask you to study about carbohydrate metabolism, lipid, and nucleic acid. There are certain markers which are derived from these metabolic pathways and metabolites. They can provide some valuable information related to particularly the cancer metabolism. Okay, those cells, what is happening. So glycolysis and TCA cycle related to carbohydrate metabolism. So increased lactate levels and expression of glucose transporters, particularly GLUT1, is seen in various cancers, and one accumulation of fumarate and succinate metabolites is seen in various types of cancers. Regarding lipid metabolism, there is increased choline levels, and fatty acid synthase overexpression is seen in many type of cancers. Though they are little non-specific, but these are some of the things which will help us to know about the metabolism, what is taking, or altered metabolism which is taking place in the cancerous condition. Similarly, in protein metabolism, we have increased glutamine uptake and utilization. There is particularly dysregulation of serine and glycine metabolism which is seen. And of course, in nucleotide metabolism, there is increased levels of deoxythymidine, okay, which is seen. So certain these things also can be picked up, and they can be added to the list because they are not so expensive. They can be easily done, and that may help us to plan particular treatment or see the response to the treatment, okay, by using these markers in cancer patients. Cells as cancer biomarkers, yes, these are the 3 cells which are seen, and these cells tend to emerge in circulation in advanced stages of tumors, and they can be readily tracked, and they will give us some insights about what is happening in a particular type of cancers. For example, circulating tumor cells can be studied, and they give an early and accurate indication of the progression of the disease and survival. And particularly they are used in these 2 cancers, that is breast cancer and prostate cancer. Similarly, immune cells, okay, or we call it as ICs. So immune cell count and in the scan tissue and histopathological examination of the tumor infiltrating lymphoid cells, that will give us an insight about the metastasis of that type of cancer. And cancer stem cells. So this is another entity which is seen. These are a small population of cells that can self-renew, and they produce more differentiated cells to propel and sustain the tumor cells. So this was first detected in acute myelogenous leukemia patients, and even they also help us to tell about the progress of the disease. Particularly, they are mainly concerned with the metastasis. Okay, so whether the cancer has progressed far enough for metastasis, and whether it is invading the other tissues, so that can be detected by seeing these biomarkers, that is circulating tumor cells, immune cells, and cancer stem cells. Next, lamins as cancer biomarkers. So we know that nucleoplasm, nuclear pore complex, and lamina, they are the three main constituents of multicellular nucleus. And the main element of this lamina is a group of class 5 intermediate filament proteins that are termed as lamins. Okay, because they are the ones which are involved in controlling the differentiation, apoptosis, gene expression, and DNA repair mechanism, either some of them in direct way and some in indirect way. So, and they are the ones which are abnormally expressed in tumors. So these can be detected, and there are various types of lamins as A, B, C, and those things. So just to highlight a few, in lung cancer, lamin A or C is going to be overexpressed. So that is going to tell us if the overexpression is there is increased migratory property of these cancerous cells. Similarly, in gastrointestinal cancer, the same lamin A or C is underexpressed, and that is going to tell us about the invasiveness of the tumor. In skin cancer, lamin A is again overexpressed. Again, it's going to increase the migratory property, okay, just like lung cancers. And in pancreatic cancer, it is the lamin B which is overexpressed. Again, it's going to cause invasiveness of that tumor, and if it is overexpressed, we know that the prognosis of such type of cancer is poor. So like this, the lamins can act as biomarkers which can tell us about the tumor, how aggressive they are, and what is the prognosis if the level of these proteins are increased. Next, coming to the galactins as cancer biomarkers. These galactins are a class of beta galactoside binding lectins, and this galactin expression is linked to genesis, progression, and pathological aggressiveness of the tumors. So there are again various types of galactins. Among them, the galactin 3 is the one which is a malignancy function related biomarker. It is studied and a lot of things are categorized based on this galactin 3. And the galactin 3 cancer characteristics, what it has is it promotes the tumor growth and angiogenesis. Okay, so these are all the things which is happening at a little advanced stage. If you pick up these molecules, the blood or in sample, they will tell us about age in which they are. Of course, when you institute the treatment and look for these type of molecules, will tell what is the response we are getting from what has been instituted. So various cancers like pancreas, squamous cell tumors of head and neck carcinoma, then breast cancer and cancer of GI tract metastatic illness, all these the blood galactin levels is increased. Particularly what we look at is the galactin 3 levels in the blood. Carbohydrate antigens as biomarkers, I think we know about these things, and it's already been done. Okay, so these Ca carbohydrate antigens, they are glycoproteins of high molecular weight. Ca19 we know test it for detecting malignancies of digestive organs. Ca125 is detecting ovarian cancer recurrence and evaluating the therapy response, so it can be used. Not only for the screening or for the diagnosis, even for the monitoring of the treatment we can use. And carcinoembryonic antigen Ca levels can tell us about the high risk of gastric, colorectal, breast, and ovarian and lung cancer. For some of these things are non-specific and some are specific. So while ordering the test, we need to take a call which one has to be ordered, so that it's going to help us in the diagnosis and patient care. Moving on to viruses as cancer biomarkers. So we all know the hepatocellular carcinoma, which is one of the most widespread viral tumor. Okay, here the risk factor, the chronic hepatitis viral infection, which is primarily caused by hepatitis B virus. And how does this cause is HBV can induce tumorigenesis by causing genomic instability. So that is the mechanism by which it produces. And I think that detection is going to help us, because there are other modalities by which we can diagnose the cancer. Just to add to the list, you can also use viruses as cancer biomarkers. Similarly, cervical cancer, which is triggered by a particular strain of HPV virus, human papilloma virus, and this is the second most prevalent cancer in women, which has got that importance. Chronic infection of HPV is known to be linked with causation of cervical cancer. Of course, now I think the vaccine is available, that it's going to help us to prevent this cervical cancer. Yeah, moving on to the exosomes as the cancer biomarkers. So these exosomes are particularly the extravesicular entities which has got a diameter of 30 to 150 nm, and which are all the cells which secrete these exosomes is the epithelial cells, erythrocytes, dendritic cells, endothelial cells, and oligodendroglial cells, mesenchymal, as well as the tumor cells. Okay, and they particularly act as cellular postman to carry the genetic material for inter and intracellular communication. Okay, so that is the function what they do, and they can be easily detected in blood and even other fluids like breast milk, synovial fluid, amniotic fluid. Particularly urine sample, you can see the exosomes. Then bronchoalveolar lavage fluid, pleural fluid, serum, as well as even saliva. So what these exosomes they do is they encourages the epithelial mesenchymal transition, okay, which happens in the cancer cell. So that's why this has come into limelight. Can be easily detected and can help us in as a cancer biomarker. They are potential cancer biomarkers because of their occurrence in various biological, physiological fluids which we have categorized. Particularly what we look at regarding exosomes is this entity. One is the tumor-derived exosomes, because they construct or modulate the tumor microenvironment, and they are involved in to encourage angiogenesis and tumor invasion. And they are abbreviated as TEXs. And there are plentiful cancer-related proteins which are formed or which are seen in these exosomes, as well as the exosomal nucleic acids. Okay, because the lipid bilayer is going to protect the exosomal nucleic acids. So even these things, entities can be looked in the exosomes, and they can help us in to act as cancer biomarkers for diagnosis and categorization of various cancers. So some of the applications you can see overexpression of proteoglycan, the GPC1 protein. They are the exosomes. They are seen in exosomes which are secreted in pancreatic cancer. Similarly, higher levels of exosomal protein 4. Okay, these are all the proteins. So they are. It is seen in pancreatic ductal adenocarcinoma. Similarly, you have overexpression of the transient receptor potential channel 5. Okay, this is in exosomes of breast cancer has been detected. Exosomal microRNAs, okay, they again serve as a very important tool. They are been associated with the hepatocellular carcinoma. Similarly, elevated levels of microRNA, the 375 and 1290 levels, they are seen in prostate cancer. So like this, we can utilize these exosomes also for the various types of cancers in diagnosis, prognosis, as well as the determining the treatment outcome. Next, we will move on to the last component about the precision medicine in cancer care. So this precision medicine, they are also times used as personalized medicine or even utilized the way of healthcare which healthcare provides, which can offer a plan or as a specific care for the patients, okay, based on their genes, proteins, and other substances which are present in the body. And with regards to cancer, most often it means of looking at how changes in certain genes or proteins, like the markers what we have enlisted, okay, a person's cancer might affect their care, such as planning for their treatment options. So this is largely based on knowing the effects of changes in certain genes and proteins inside the cells, and clinicians can use this information for to order relevant lab tests and to put them together as a plan of care, and that can serve as more accurate diagnosis, specific recommendations for the treatment for the patient, and improved treatment in cases of cancer. So for example, the empirical medicine, what happens is it's going to categorize all the people one roof, okay, and they, of course, the diagnosis is done based on various modalities, and while instituting treatment, they will put on drug A, and in case it doesn't work, okay, then they will change it to drug B and so on, okay. But everyone is put under one roof. Whereas in case of precision medicine or individualized medicine, so all these people are tested appropriately. Even in testing also, the precision medicine can be used. So which person requires what test, so it can be ordered. Then of course, usually they are segregated and they will put each one on a different type of treatment. If drug A is working well on a set of patients, that is given. Similarly, on other set drug B, similarly other set drug C. Not only drug, even the other modalities of treatment also can be determined based on this. So precision medicine in cancer care, it will help to identify people who might be at higher risk for cancer. So that also can be done while screening. Can help with the high risk people to lower their risk as well. Can detect the cancers early. This is very important because in, I think, cancer care, to detect it late, then there might be a lot of damages which has happened. Aggressive type of tumors might be very difficult to control with any form of treatment. It will help to diagnose specific type of cancer correctly. Again, this is another thing which is important because many of the markers what we have available today, particularly in diagnostic, they are quite non-specific. They might indicate 2 or more types of cancer. Okay, but with, I think, precision medicine, we are going in for a particular set of testing, can accurately diagnose or correctly diagnose what type of cancer, that treatment can be instituted. You can choose which cancer treatment options are the best for that patient, and then evaluate how well the treatment is working for that patient. So types of cancer where now precision medicine has been used, just went through the list. There are about 10 cancers: colorectal cancer, breast cancer, then lung cancer, thyroid, and melanoma, and certain types of leukemia and lymphoma, esophageal cancer, gastric cancer, ovarian cancer. In these, the precision medicine has been tried, and they have been evaluating. I think the outcome is going to be a lot better than a generalized or empirical treatment. So challenges and future directions with cancer biomarkers. Yes, we have, particularly in diagnostics, we have things. One is what we are concerned is about the false positives and negatives. These are the current limitations of the various biomarkers. That is going to reduce the diagnostic accuracy, leading to either unnecessary treatments or sometimes missed diagnosis. And that's why there is a need for enhanced precision in biomarker development. Next thing is about the cost also, because we are not sure about how to diagnose and what is going to happen because of the restricted biomarker use. So unnecessarily, I ask the patient to spend a little bit more what they are affordable. And of course, many of these things are not widely accessible also. They are available only in certain are the thing. And along with that, of course, because of the heterogeneity and complexity of various types of cancer, also requires a comprehensive characterization, so that going to help us in the future about the precision medicine. Of course, standardized assay platforms and protocols needs lab. We develop these protocols and data analysis methods. Not going to be helpful for the patient care diagnosis. Regulatory approval and clinical adoption. So many markers which has come. This requires rigorous evidence of clinical validity, utility, and patient benefit. So this needs to be analyzed, and then it has to be given to the public. And lastly, the clinical relevance and utility, because ultimately when we use a marker or a set of markers or diagnostic elements in the patients with cancer, it should guide the treatment decisions and improve patient outcomes. So that has to be kept in mind. So future of cancer research, first thing is research in identifying new markers. Already there are a lot of them in the pipeline. Okay, and particularly we put it as the novel biomarker discovery. If we have certain marker or a certain set of markers for each of these cancerous conditions, that will be a lot more helpful for the patient care. Second thing is utilizing big data analytics. So because technology is the one which is going parallelly with us or the medical field. So we need to adopt these things so that it can uncover the patterns and correlations, and which can help us. Integration of big data is another which is important. And last but not the least is incorporating multi-omics approach, which is going to integrate genomics, proteomics, and other omics related fields, okay, into these diseases and potential biomarkers. Multi-omics approach is what is something what can be done for or seen in near future. What we have unlocked is about the first thing, biomarkers. Mainly they are the elements which are objectively measured, evaluated as indicators, so which can help us to detect the cancers. So markers of cancer can be diagnostic, can also have the prognostic and predictive markers. Then types of biomarkers, we focused on 9 entities, but amongst them, the most ones which are used is the genetic, protein. Nowadays, they are using the cells and metabolic and exosomes. These are the ones which are used. Regarding precision medicine and cancer care, they are the specific care which can be given to this cancerous particular type of cancerous patients, and personalized treatment options can be thought of, so that it's going to improve the patient care. Challenges and directions in near future. Yes, there are a lot of things which we need to look at. The false positives and negatives is one thing which we have to see. The accessibility and cost is second thing. Most important is the clinical relevance and utility. And future of cancer research, of course, discovery of novel biomarker, particular type of cancer, integration of big data, and the treatment. Dedicate this to my friend who fought CML age, surgeon from Mysore, good friend. Yeah, namaskaram.
Thank you for this intellectually enriching. Now we are open for questions.
Since, yes, sir. Thank you, sir.
Myself, Sudhir from the Sridevi Institute.
Yes, sir.
It was protein biomarkers. You have
Yes, sir.
the upregulator.
Yes, sir.
Series. Those are which disease, which cancer, which this regulation is in.
Yes.
And one question: what are the test we should do in the lab finding this regulation? A question. B question: what is the picture in the metastasis? This biomarker. There is the same picture the biomarkers.
These metabolic biomarkers, whether it is protein or carbohydrate, sir, they are in general. Okay, we cannot particularly say in this type of cancers these increased or decreased. So they are general. They are like add-ons to your panel, and
So they are
not disease specific. They are not disease specific.
cannot.
No, sir. No, sir. Only thing is what you can come to a conclusion is whether the tumor has it advanced or not. That is what you can think of.
Protein maybe have high protein.
Yes, sir. Yes,
Also
sir.
there is
That's why they are non-specific. But these are the things which are changes which are noted in various types of. Second question.
What is the picture of metastasis?
Yes.
The patient mostly comes
Yes,
in
sir.
our
Yes, sir.
country. The beginning biomarker.
Yes, sir. That is the thing, sir. There are few markers now what they have categorized to look for, mainly for the metastasis. Okay, so those markers can be used. Particularly the lamins is the one which they are seeing, and galactins are the ones which are which are seen. And not only just for metastasis, sir. Even after instituting the treatment, you can look at these markers because it will tell how the patient is responding to the treatment. Okay, so these are the markers which can be.
Any more questions? Now I call
Okay,
upon Dr.
thank you, ma'am.
Priyadarshini ma'am, Professor of Biochemistry, University. Thank you, ma'am. Thank you, sir. For the fourth session, we have Dr. Shabnam Ruhi ma'am. I now request Mr. Mukesh sir, our assistant professor, to introduce madam.
Thank you, ma'am. A very good afternoon to one and all. It gives me immense pleasure to introduce our next speaker of today's CME, Dr. Sabnam Ruhi ma'am, Director, Department of Laboratory Medicine, Sakara World Hospital, Bangalore. Madam will enlighten us about biochemical investigations in the diagnosis of multiple myeloma. She has completed her MBBS from JSS Medical College, University of Mysore in the year 1995. Later, she has done her post-graduation in pathology from KMC Mahe in the year 2000. In addition to this, she had done MBBA in hospital administration in 2016. She is also certified with Lean Six Sigma Black Belt, and her area of interest is hematopathology and quality management, and from 2011 she was appointed as NABL assessor. From 2011 to 2013 she had served in Apollo Hospital Bangalore as a senior consultant and lab director, and from 2013 till date she is the director of laboratory medicine at Sakra World Hospital, Bangalore. Without making any delay in the program, I welcome you, ma'am, to the stage to enlighten us about the updates of biochemical investigation in the diagnosis of multiple myeloma. Over to you, ma'am.
All of you. At the outset, I would like to thank Dr. Coordinate when he called me to come here, Raja. I was looking at where I go hardly 9. Takes me 1.5 hours. Half my day will go traveling to Christ. I could reach here in less than 1 hour. That is double, I mean, almost 3 times the distance, and in half the time I could. Why am I telling? Malignancy. My root is a malignant lesion, and this is the normal situation which happens. Which is so. With what is this? Normally called B blood, part of the WBC. When they come in contact with some plasma, they get activated, and plasma create antibodies which fight against the antigen, and they protect our body. They are having a protective function. But sometimes there is some genetic abnormality or whatever reason, these B cells and the plasma cells become dysregulated. They have no control and they go on proliferating over and over. They become these or plasma cells which actually look very beautiful under the microscope. But these beautiful cells, they wreak havoc on the body. Most importantly, bones, kidneys, the blood. Beautiful. So to understand that, always you should see looks are not important. You should not get fooled by looks. These beautiful little cells, they wreak havoc on the body. Multiple myeloma is a part of a heterogeneous group of disorders characterized by neoplastic proliferation of plasma cells. There is abnormal growth of this plasma cells. The plasma cells dyscrasias. So when these plasma cells get initiated and they become malignant, there are clonal plasma cells. I'll come to what is clonal. They form the MGUS, that is monoclonal gammopathy of, and when the proliferation becomes increasing and increasing, they want to become smoldering myeloma, then multiple myeloma, and when the eventually plasma cell myeloma. Burden of disease. The median age at diagnosis is around 70 years. Usually it occurs in elderly people, the ages of 65 to 85. Males are affected more than females, and incidence in India is around 1 per 1 lakh population. So it is quite common. Symptoms, usually the presenting symptoms is anemia. People come to the clinic with sometimes bone pain, and when they do, and some of them may have symptoms of renal dysfunction, and when you do the investigation, there will be they are called the crab symptoms, the crab feet. What is the diagnostic criteria for the multiple myeloma? WHO has given diagnostic. It says that should be clonal bone marrow plasma cell percentage of more than 10%, or biopsy proven plasmacytoma, and any one of the following myeloma defining events. What are these myeloma defining events? So there is end organ damage, like I said. So end organ damage is the kidney, bone, or the blood damage to that. This how they you identify end organ damage is by doing this blood test. Calcium will be more than 1 gram, 1 milligram per deciliter, more than the upper limit of normal, or more than 11 milligrams per deciliter. Then increase in the creatinine clearance, decrease in the creatinine clearance of less than 40 ml per minute, or increase in the serum creatinine level of more than 2 milligrams per deciliter. There will be anemia where hemoglobin will be less than 10 grams per deciliter. And then there will be bone lesions which can be diagnosed by A or CT. The other myeloma defining it, or if those are not there, even in the absence of plasma or crab features, if any one of these are present, even then it is called a myeloma defining event. That is, more than 60% plasma cells in the bone marrow is independently a myeloma defining event, or if the kappa and lambda light chain ratio is more than 100, then it is a even in absence. Or MRI lesions, when you have more than one focal lesion which is measuring more than 5 millimeters in diameter, call this a myeloma defining. Diagnostic tools for multiple myeloma is one is very most important, that is the clinical examination, followed by radiological imaging, blood test, marrow examination, and the biochemical examination. So we will be focusing our biochemical examination of this multiple myeloma. What is the role of biochemical investigations in multiple myeloma? One is they are essential for confirming the diagnosis of multiple myeloma, help monitoring the disease progression and evaluate organ progression, function, and also assess the response to treatment and detect lapses. Biochemical markers in multiple are start with monoclonal immunoglobulins, or the M protein. So I will tell you what is monoclonal here means. So your body contains thousands of antigen specific B cells. It is like on the traffic, on the road you have cars and vehicles of different types. You have lorries, you have buses, you have cars, you have cycles, motorbikes. Is there in the on the road. But here in myeloma, what happens? You have only one type. Suppose the traffic road is full of only cars. So that is your monoclonal. And in the cars also only one Maruti 800. All the vehicles on the road are only Maruti 800. So that is the monoclonal. All this different diversity is gone, and only one type of car is there. So that is the monoclonal. There is only one type of a antibody. Once activated, these normal antigen, they activate and multiply, make clones of plasma cells, and these plasma cells produce antibodies, that is immunoglobulins. They can be immunoglobulin G, A, M, or E, whatever. Then collectively these proteins are present in the body. Okay, so one of these will start multiplying more than the others. This is what happens in myeloma, where one, either IgG or IgA, it start multiplying more than the other types of cells, and in that also there will be only one type of protein which is increased, that is either kappa or lambda. So that is called the this is the structure of the immunoglobulin. It is made up of heavy chains, light green are the heavy chains, and the light chains. Light chains are either kappa or lambda types. So here in myeloma, what happens? Only one type of cell is there, and this is commonly, these type of immunoglobulins are commonly detected in the serum or in the in IgG, IgA, or just the light chain. How do we detect these globulins? To do something called the serum or a electrophoresis. So in serum electrophoresis, it is a technique in which the are charged with the electric current, and they separate based on their charge and the size. So this detects the M protein in the blood appearing as a sharp band gamma region. The pattern how it comes. Dark blue is the normal pattern. It has the albumin. Protein is made up of albumins and globulins. So albumin will separate with a different speed, and the globulins also separate. Globulins are made up of alpha 1, alpha 2, beta, and gamma. Those are the different globulin. So they will be separated. The dark blue is the how the normal separates. But if it is multiple myeloma, there will be an abnormal peak in the gamma region. Light blue is the abnormal peak where there is a sharp peak or the gamma peak. You have to note that only 80% of the patients with multiple myeloma show this one. This remaining 20% will have only the urine protein electrophoresis detect the benz protein. They are the free light chain. Benzones proteins are often excreted in patients with multiple myeloma. We have heard, I mean, biochemistry basics. You have learned that benzone protein, if you heat the urine, it appears at a certain degree and then again disappears. You heat it further. So the benzones are better detected by this urine protein. Usually take a 20 urine specimen, identify these. This urine protein electrophoresis separates the proteins according to their size and electric charge, and then it quantifies the amount of benzene present in how it looks. Light chain. The next diagnostic modality is the immunofixation or the typing. This is more sensitive than the electrophoresis. Helps to confirm the type of monoclonal protein, whether it is IgA, or IgG. Indication for this is you have found M spike in electrophoresis. Whenever the multiple myeloma is suspected, even with normal electrophoresis, this happens in AL type of and non-secretory myeloma, and it is also used in monitoring the disease. What is the difference between immunofixation and immunotyping? Fixation is the conventional method of diagnosis. The manual procedure uses a standard gel electrophoresis to separate the proteins. And this is, they separate the protein, and then you are adding antibodies to the serum, and then you are identifying the antibodies. Then immunofix typing is the latest one, which is automated. It is capillary electrophoresis. Detect this. Coming on to the light chain assay, serum. So the first diagram is the intact, where you have heavy chain. The orange region place where it is target where the test assay is hitting. So these are hidden normally in the intact globulin. These target areas are hidden, but in multiple myeloma, what happens? These get separated and get exposed. Then the whatever the FS assay will target these orange regions and then detect the amount of kappa or the lambda. So light chains are components of immuno. They're free or orphan elevated in lambda light chains are same. And in most patients, either kappa or lambda. Like I told you, only one type of car is there. So that car is the Maruti 800, or it may be whatever Toyota or whatever. So most patients, either only one type of thing is elevated, either kappa or lambda light elevated. Therefore, the ratio between the kappa and lambda is altered, or it is, or this multiple. This test may be used to monitor the progression and or the treatment. Importance of why this test is so important is one of the latest tests. In 20% of the patient, only this is elevated, whereas the serum electrophoresis may be normal. So this is the screening algorithm with the diagnostic. When you're doing just serum protein electrophoresis, you will diagnose only 87.6% of the patient. Remaining 12.4% are, you combine this serum protein electrophoresis with serum and urine immunophilia, you might diagnose up to 98.7% of your patients. But if you combine serum protein electrophoresis with free light chain assay, then 100% of your patients can be diagnosed. So the importance of doing the free light chain assay. So free light chain assay testing, in addition to improves the detection rates and eliminates the reliance for not do the urine electrophoresis at all for you are doing this free light chain assay. The next biochemical marker is the beta 2 globulin. So this is a kind of an antigen which is present in all the nucleated cells in the body. It is in the MHC1 region of the globulin. Forms one of the chains of the major histocompatibility complex molecule normally present on the surface of every nucleated cell in the human body. Presents antigens to cytotoxic cells that are carrying out surveillance to infection. It is elevated in most of the patients with multiple, and it correlates with the disease burdens in and also in the albumin. It is often decreased in patients with multiple myeloma due to the production of abnormal. This is not a biochemical test, but is a very important, so I have included the bone marrow analysis, bone marrow biopsy and aspiration, and this is the gold standard for the diagnosis of multiple myeloma. It identifies the number of plasma cells in the bone marrow, and more than 10% is a key diagnostic criteria for yeah. And that is the aspiration. The first picture is the aspirate and the second one is the biopsy. So both are required for the diagnosis. Coming on to the cytogenetic for chromosomal abnormalities that may or prognosis. influences prognosis and therapy. There is a risk stratification based on the type of chromosomal abnormality that is there. So there is a standard risk, intermediate risk, and high risk. You need this to go further into. Additional diagnostic tests are calcium level, which is again part of the diagnostic criteria, myeloma. Hypercalcemia is common in multiple myeloma due to bone resorption. So it is one of the CRAB criteria which identified cellular or end organ damage. Renal function test, kidney function test often declines in multiple myeloma due to the deposition of this abnormal protein. It is called the fast neck. Tests for the renal function include creatinine, blood urea nitrogen, and glomerular filtration. Of course, the complete blood count is ubiquitous. Every health, the doctor, first thing they write is a CBC and a ESR. This shows commonly anemia in my patient multiple. There may be leukopenia and or thrombocytopenia in some of the advanced. Then coming on to the staging and prognosis of the, there is a, initially they came up with the based on beta-2 microglobulin and albumin levels. It is used to predict disease progression and survival rates. It is divided into stage 1, stage. Stage 1 is less beta-2 microglobulin less than 3.5 milligrams per liter and albumin is above 5 grams per liter. Stage 2 is beta-2 microglobulin between 3.5 and 5.5 with any albumin level or albumin level less than 3.5 and beta-2 microglobulin less than 3.5. That is stage 2. Stage 3 is some beta-2 microglobulin level greater than 5.5. So these are the stages, but later on they came up with a modified ISS staging system. This is a revised international staging system. They added genetic risk as assessed by fluorescence in situ hybridization and also added the LDH as a marker for prognosis. So the revised criteria adds beta-2 microglobulin which is less than 3.5 milligrams per deciliter, albumin greater than 3.5 or equal to 3.5 grams per deciliter, standard risk chromosomal abnormality and a normal LDH level. Stage 2 is either stage 1 or and stage 3 is from beta-2 microglobulin greater than 5.5 milligrams per deciliter and either high risk chromosomal abnormalities or high LDH. This is stage. Summarizing, age, kidney function and genetic mutation are important prognostic markers. On to the case study. The 36-year-old male came with severe backache to our with a history of spinal fractures which were on MRI. His hemoglobin was 7.9 grams per deciliter. Platelet count of 101,000 per microliter. Creatinine 1.2 milligrams. Benz Jones protein negative. We did the conventional heat, not the. Calcium was slightly elevated more than 11. The serum protein electrophoresis, right? Dark peak, that is the band which is contrast with the normal where you can that region, whereas the albumin has a peak. This one is the normal electrophoresis. The patient result I think was more. Did a free light chain assay, upper free light chain assay used by immunoglobulin. Gold standard is the nephelometric, but we have the by that, and it was elevated, and the kappa lambda ratio was 48 high. IgG kappa monoclonal gammopathy was detected. Bone marrow examination showed increased plasma cell hypercellular marrow with did I with C38% of plasma cells of this marker than 10. Yeah. Out markers, further markers, and to confirm monoclonality. Monoclonality has to be confirmed with ISH. Did that, and it showed um, right kappa light chain resisting genic aberrance and clonality. The picture of the ISH. Now kappa light chain trap, that is organ damage was noted. Although this is not a typical case, here the patient is not in that elderly group, it is quite young. So think of this even in the younger age group. So now this cancer is happening in elderly person. Had all the, and also the creatinine was not very much, it was elevated but not more than, but M band which was light chain kappa lambda ratio, and marrow shows increased plasma clonality, which is the diagnostic. So this was confirmed as multiple based on biomarkers and bone marrow examination. Follow up, the M band consistent stopped after this is after 2 the repeated peak. After further 2 months, so serum electrophoresis is not only important for diagnosis, it's also important for checking the disease progression and your effective. The basic diagnostic algorithm is, one is the signs and with anemia and or pain, where you see anemia, and on the peripheral smear formation, stomach is elevated. SR biochemical test is increased total protein, increased creatinine, hypercalcemia, is proteinuria, abnormal immunoglobulins, low albumin, and low anion gap. So these are the biochemical per se. And then there are some myeloma specific tests follow up with, that is serum electrophoresis typing and serum free light chain assays. So the basic diagnostic algorithm which you do whenever you get a case of patient who is suspected to be having myeloma. Confirm. So to conclude, biochemical diagnosis of multiple myeloma relies on detecting, that is the M protein, light chain, and assessing organ function and bone. Tests like serum electrophoresis, immunofixation, and bone marrow analysis are crucial to confirm the diagnosis. The direction, ongoing research, my previous speaker spoke about all these biomarkers, they are still under research. So they may help in early detection and monitoring of treatment efficacy. Final thoughts, biochemical testing is essential for accurate diagnosis, staging, and prognosis of multiple myeloma, guiding the clinician in selecting the most effective or strategy. Biochemical are very, very important for treating the patient. In a month, we get 2 or 3. Ours is not cancer center. We have just oncology. Most of them we get to come for a general checkup. Sometimes uh, preventive health checks we check sometimes. I didn't present that case. Had a case where just we saw one odd plasma cell peripheral, and then we did the workup, and then that he had a case of plasma cell. It's quite. I mean, generally, ours is not a cancer center, so I cannot tell you the statistics. But
I
then
just
we,
wanted to know.
yeah, we come across 1 or 2.
For the session. Now I call Dr. Reena ma'am. Kindly felicitate ma'am. I'll now break for lunch. For the students, I request please stay back here. There's an MCQ based online quiz competition for the first time MBBS students that will be conducted by Mr. Mukesh sir. So students, please be seated in the theatre hall and here. Meanwhile, I request the delegates to please head for lunch. A lunch has been arranged in ACS Convention Hall. Please assemble back by 1:45. Students, please be seated.
Hello. Very good afternoon, students. So, are you ready for the quiz competition? Yes. So actually the time is only 15 minutes. So I am just going to share the link. Okay. And you have to enter some details. You have to enter there your name, roll number and mail ID. After that, you go to the second section and start answering the questions. So 20 questions are there and you will get only 15 minutes. Okay, only 15 minutes will be there. Better you log in with a Gmail account, as already I have told you in the class also. Right, try to log in with a Gmail account, it will be good. So only 15 minutes will be there. So try to avoid the technical glitches. Okay, once 13 minutes get over, try to finish it. Okay, submit your answer. Otherwise, if you're not able to submit on time, you are responsible. Okay, no second round for the quiz. Is that clear? Right? Are you ready? Yes. And after submission, you can go for lunch. And again, you have to come back here by 1:45. Right? Your attendance we will take here only through the biometric. So you have to come back. Okay. So I am sending the link here. Are you ready? Okay. Go ahead. All the best. No discussion. Whatever you know, you please write. Don't know whether your friends are knowing the correct answer also. You try to finish. Try, try to finish within time limit. By the end of 13 minutes, you should finish the submission. Otherwise, technical glitch will be there. I am telling you.